Welcome to Break Everything. Your host, Lisa L. Levy, will guide you through critical thought conversations and a journey of directed disruption that makes a difference. Experience bold conversations with industry leaders who are willing to challenge the status quo.
In every episode, I interview interesting leaders in the healthcare space. If you're joining us for the first time, hopefully you're watching us on YouTube, LinkedIn, listening on Apple Podcasts, Google Podcasts, Stitcher, Spotify, and more. Our guest today is Dr. Robert Groves, a trusted healthcare technology leader who's brought his unique style of energetic leadership to the world of healthcare in a career that has spanned 4 decades. He currently serves as the Chief Medical Officer and Executive Vice President at Banner Aetna, a joint venture health insurance company in Arizona, leveraging the strengths of both the #1 healthcare delivery organization in Arizona, Banner Health, along with a highly respected and successful national insurance brand, Aetna. He's led initiatives to use technology to improve care, whether by developing virtual care, and tele-ICU programs for some of the largest providers in the United States, leading corporate strategy for innovative new payers, or advising some of the world's leading software brands on clinical engagement strategy. He's a published author, speaker, advisor, and the creator of the Groves Connection, a movement and podcast centered around changing healthcare to one that's more sustainable, inclusive, and beneficial for all. It should be pretty obvious today why he's here with us. Dr. Groves, welcome to the show.
Thank you very much. It's great to be here. Thanks for inviting me.
I look forward to our conversation today. So, Robert, I did the formal introduction, and that's the nice stuff, but it's really most impactful when you tell us a little bit about your story. How did you find your way into healthcare?
Sure. Well, it was pretty straightforward in my case in that my father was what was at the time called a general practitioner in South Georgia. And at that time, I used to go on rounds with him. I used to make house calls with him. I was very interested in being like Dad, and so I fell in love with it because I saw the relationships that he had with his patients, and they were just so warm, and it was obvious that they cared, that he cared, and that they really respected him, and it was just something that I wanted to do one day. I wanted to be able to help people like that.
It's fabulous. And in your career, you've done many different things. Practicing medicine is only a piece of your background and your experience. What's the best part of your current role?
Oh, gosh. Well, like with any role, the best part of my current role is the people that I work with. Tom Grote, who is our CEO, is certainly one of the best bosses I've ever had. Joanne Mizell, who is our Chief Operating Officer, is so knowledgeable about the details and the complexity of the health insurance business. And, Dan Keller, who is our CFO, a guy that falls in love with spreadsheets, which is beyond me how anybody does that, but that's who you want as your CFO. And so the team that I work with is phenomenal, and we've been given the opportunity to have an influence on the trajectory of healthcare in this country, and that's a huge opportunity. So it's just great to work with people who get it and who are really trying to do the right thing.
And it is a fabulous thing. So the combination of Banner and Aetna is unique. What is the driving mission of the organization? What are you trying to do?
The driving mission of the organization is to fix healthcare, essentially. I mean, we have a series of fundamentals that we discuss on a weekly basis. And number one is we're here to fix healthcare. That's what we're doing. And I've heard Tom Grote say very specifically, and he says to this day, look, if at the end of our term, if you will, if we have the largest presence in Arizona and we are profitable and all of those things are true, and we haven't addressed the issues that plague healthcare, then we will have failed. So it's about making it more accessible. It's about making it more affordable. And it's about making it easier for patients to do business with a healthcare payer. We all know what the problems are. They're not easy to fix, or someone would have done so already, but those are the very things that we're working on.
one of the things as I've had these conversations with others is the challenges aren't easy to solve, or we would have already solved them, obviously, but they're also not out of reach, I guess is the phrase I want to use, right? They are all fixable. They're just complicated and complex with layers of things.
Yeah.
And so the fact that you have that dedicated focus to start peeling back the onion, as it were, and trying to fix layer by layer is absolutely fabulous. In the work that you do, and you had some good fun, poking at the CFO and, love of spreadsheets, and all, you're right, all CFOs, spreadsheets just, my brain explodes sometimes. But with that, the industry, healthcare as a whole, is driven by metrics. What is that? What's your take on that? Is it important? Is it helpful, or is it hurting us?
It's a great question, and here's why. We have fallen in love with metrics, and there's good reason for that. I am not against metrics. They are incredibly useful in process improvement. They are incredibly useful if I'm internally motivated to improve and I can see where I stand with respect to others in terms of quality or cost or efficiency. All of those things are incredibly important to me because I want to be good. And most physicians want to be good doctors. They want to have, they want to be cream of the crop. And so this is not about metrics, but one of the things that we've done with metrics is that we have started to tie them in a big way to reward and punishment. And by the way, this is one of the areas where my opinion has shifted. I have long been a proponent of pay for performance in the old model. And what do I mean by the old model? What I mean by the old model is you put individual physicians' payments at risk based on metrics that are collected on a regular basis. And we see this, you're aware of all the ways that we measure this, whether it's in managing diabetic populations. Have you looked at their eyes? Do you have their hemoglobin A1C below 9 or below 8, depending on what the limit is? And you add all those things up, and dear doctor, if you do a great job on these, then at the end of the term, we will reward you with cash. Now, I'm not saying that doesn't drive improvement of those metrics. It certainly does. The question is, does it make me a better doctor? And one of the predictable phenomena of attaching reward and punishment, particularly if it's a substantial reward or a substantial punishment, there are a number of things that can happen. Number one is that the data are going to get, let's call it, massaged all the way to outright fraud. And because the stakes are high, over time, you stop getting this very information that would be helpful if you wanted to change the way things work in healthcare. So that's number one. Number two, and we see this problem, by the way, not just in healthcare, but across industries. It's the same problem we see in teaching to the test with No Child Left Behind. The focus is exclusively almost on the metrics, and every other aspect of teaching, whether that's mentoring or, particularly for kids in elementary school, how to behave, and all of those things that go into being a human being in relationship get pushed to the side so that we can make this metric, because my job may depend on it. The funding that I get in my school may depend on it. The same thing is true of healthcare, and it's true in almost any circumstance where you start to measure and attach reward and punishment to those measures. I mean, literally, what I'm calling into question is almost gospel now. You remember the old adage that if you can't measure it, you can't manage it. I'm not disputing that notion. What I'm saying is when you attach substantial reward and punishment, that's when you get into trouble. And it is my belief now that that's a major contributor to burnout. We've reduced human beings and the management of companies to a number. It's really an advanced form of Taylorism. Frederick Taylor, early in the century, or the last century, developed the scientific management theory, which said that in manufacturing, we need to be very specific about what the task of a given person is. And that's all well and good in manufacturing. But when you move into knowledge workers, most of our motivation is internal. It's not external. And in fact, the data show us that when you reward someone for something for which they are already internally motivated, what you end up doing is dampening that motivation. You actually make it worse, not better. I know
so
anathema, but it's what I've come to believe that we have a real problem with.
Well, and considering that in your youth, right, you were making house calls with your father, right, reconciling where the practice of medicine is versus what you saw that inspired you in the beginning, it has to be frustrating.
It is frustrating because I believe that healthcare is about relationships. It's the relationship between the physician and the patient. That relationship of trust and caring is what allows the physician to influence the behavior of the patient. If the patient doesn't believe that you care, if you're staring at a computer the whole time and only give them 3 minutes to express themselves, and if they don't trust you because you can't look them in the eye, you can't relate to them because you're just putting numbers to everything, then my ability to influence that patient gets lost in all of the numbers. And I think that's what we've started to think of technology almost as a replacement for the delivery of healthcare. And it's not. It's simply a tool. It should be a tool that supports that relationship, not interferes with it.
And I know that I might be taking a left turn here, but there's also currently a rise in the idea of the role of direct primary care, right, where we have physicians who are going back to a way of doing business that is about the relationship first. Do you see that as a trend that will continue to grow?
Yeah, I do think it'll continue to grow. And there are problems with direct primary care, in particular for the uninsured. Of course, they won't have access to that. There are levels of direct primary care, sometimes sponsored by an insurance company, but you can go out today in most major metropolitan areas and sign up for concierge medicine, which is another direct primary care strategy. The advantage of direct primary care is it makes probably the most important part of the relationship essentially free per visit. In other words, you're paying that monthly, you can call it a premium, call it whatever you want. You're paying that monthly retainer up front. And so visiting the physician then becomes essentially free. And so you're likely to do it when it needs to be done rather than putting it off because it'll be another charge that you hadn't accounted for. It also allows the physicians in most cases to have much smaller patient panels, so that they have more time to spend with each patient. And finally, it allows them to do what they actually think is best for the patient, rather than thinking about, what will my billing be if I do this, that, or the other. The challenge, of course, is you still need insurance because if you get hospitalized, if you need to see a specialist, that's not covered under those direct primary care access issues. But it is very effective if sponsored by an insurance company in controlling costs, improving the relationship, and getting back to a more fundamental doctor-patient relationship, which is what I think should drive healthcare.
And I'm going to guess that in your current role with Banner Aetna, getting back to that primary relationship between patient and doctor is high on your list of priorities.
It is high on the list. It is difficult to do for all the reasons that we talked about. One of the challenges in healthcare is not just that it's incredibly complex. It's grown up as a sort of kludge, if you will, over the years, but also that there are lots of entrenched interests. And those interests are not easily dislodged. They have lots of money. And I've said over and over on my program and elsewhere that there aren't intrinsically bad people in big pharma, in PBMs, in insurance companies, or in the delivery system. It's a system that encourages the kinds of behaviors that we're seeing. And it's made worse by our being so enamored of metrics.
I totally get the connection, and we're doing this. I apologize for the background noise that I'm certain you're hearing now because it's just that time of day. So I want to ask this other question talk about your hopes for the future of the industry. What the things that you're working on with Banner Aetna, what are the top 2 things that you think are going to make the biggest difference?
Well, from a very practical standpoint, there are a couple of issues that I think are really important. Number one is the biggest dissatisfier for patients, for doctors, and quite frankly, for us as a payer, is a little something called prior authorization. It's an archaic process now that takes weeks, if not longer, to figure out. And there's a lot of finger pointing. The doctor's position is, look, I'm the doctor. I ordered this test. Why won't you pay for it? The patient gets caught in the middle. They show up for an exam that won't be done because it hasn't been authorized yet. And this whole thing is such a mess. We're continuing to push on that. It's a tough road because of entrenched interests, because of the notion that if you open it up completely, then doctors don't necessarily practice evidence-based medicine and they will overdo. But it is something that I believe, particularly with artificial intelligence, can be solved, and it can be solved today if we get the right people at the table that are willing to make the changes that are necessary. A lot of this information ought to go up front, not on the back end. I can elaborate on that at some other time, but that's a big issue for us. The other issue that I'm passionate about, obviously, is metrics, and I think we have a long way to go there, and that's a societal issue, not just healthcare. And then finally, I've become enamored of a strategy called continuous remote care that I discovered. Virta, the company that we brought in for reversal of diabetes, is the company that coined that term. And I think that's the secret sauce to how that system works, so that at a year's time, 60% of their patients are off all diabetes specific medication. They've lost 10% of their body weight, and their A1C is at sub-diagnostic levels. In other words, if you just looked at the lab, you wouldn't know they were diabetic. The way they do that is continuous remote care. And by that, I mean the exchange of information between the patient and a care team on a regular basis. They'll be in touch with somebody 3-4 times a day for the first months of that program. And the ability to engage anytime that I have a question. I'm going on a trip, and what should I eat, and how should I prepare for this? Those things that come up every day that you don't want to wait 3 months till the next time you see your doctor, and you don't want to make a call in because you know it's going to take a while for them to call back because they're busy. So continuous remote care, prior authorization, and the tyranny of metrics, to use Jerry Mueller's term, are the 3 things that occupy my attention today.
All right. And my final question, if I gave you a magic wand and you could wave the wand and fix something in healthcare, you have no time constraint, you have no budgetary constraint. If you were to wave the magic wand, what would you do with it?
Wow, that's a lot of power. The first thing that makes me nervous about that is no matter what you do, there are always going to be unintended consequences. I think if you talk about healthcare overall, then a broad understanding of the challenge by the general population, part of what you're doing with this podcast, is critically important, because until it's understood better, we can't make the necessary changes. And this is out of yours and my individual control, but we need a change in tone in our political system. Can't accomplish much, frankly, until we get that. And the truth is, what we call healthcare, the rescue medicine system that we spend almost $4 trillion on, only accounts for about 15% maybe of health span and lifespan. The rest of it is in the social determinants, habits. Genetics plays a role, obviously, but those are social issues. And we're asking healthcare now to address social issues. And that's because I think we've reneged on our responsibility to address them as a society. So if I had a magic wand, we would be investing a lot more in those social determinants of health. And we'd be doing it as a society, not isolated to healthcare.
I absolutely appreciate your perspective, Robert. I appreciate you for being here, sharing your thoughts and your experience. It is a broad perspective that we're sharing with the audience today that hits on the industry, but the social ramifications of what needs to actually happen for sustainable change to occur. I have very much enjoyed our conversation today. This concludes the show. We look forward to you joining us on other conversations throughout the Break Everything experience. I wish everybody a great day. Thanks so much for joining us.
You have just experienced Break Everything with Lisa L. Levy. Critical conversations on directed disruption that makes a difference.